What if I told you there were 6 tests that you could take right now that would give you the motivation and inspiration and focus that you need to live 10, 15, or 20 years more of a healthy, active lifestyle? Sounds good, right? Problem is, they do exist, but your doctor doesn't even know what they are. Stay tuned and listen to us today, me and Dr. Deep, as we tell you about 6 diagnostic tests that will give you the motivation and the focus that you need in order to have the happiest, healthiest, and most successful life possible. I'm Jack Murphy, and I'm the co-founder of Rebel Health Alliance and the co-host of our podcast here. Dr. Deep, introduce yourself.
Hey, Jack. Dr. Deep here, Chief Medical Officer, co-founder of Rebel Health. Excited to be here talking about an important topic today.
Indeed, there are some scary things out there when you realize that many or most or practically all of your doctors have no idea the proper diagnostics to give you. They're supposed to be the ones that you can go to and rely on to be on the cutting edge of science, to have your best interests at heart, and to know all of the little details about your health and well-being so that they can help you, avoid chronic disease. That sounds like a good plan, doesn't it? But I think most of them are stuck in like the 1980s. There's been an evolution in technology. There's been evolution in the thought process behind how do we measure what's going on in your blood and how do we use it to predict what's going to happen to you? How do we use your blood work to decide what kind of treatments you might need or not? Plus, there's other new tests that no primary care physician is ever ordering you, but we're doing that here at Rebel Health.
Jack, I'll make one comment here, which is, you mentioned that most primary care docs don't know what half of these things are and they don't order them. And there's a reason for that. One is because, insurance doesn't pay for it in most circumstances, which is unfortunate because they are much more predictive of downstream development of chronic disease, of atherosclerosis, of cardiac events, strokes, than the typical, small lipid panel that your doctor might be getting every year or so. The other reason, like you mentioned, is many physicians are kind of stuck in an antiquated model of practicing care. When they have 5 or 7 minutes to get to everything they need to get through, to check off the boxes, to make the man happy, we don't actually have time to delve deep into what some of these laboratory tests mean. And so we just push the button, the standard order set, and whatever our system is sort of approved, that's what kind of goes out. And so often I've unfortunately heard our patients come to us and say, well, I asked my doctor to test this or that or the other, and they said no, or they made fun of me, or they asked me what they were going to do with that information. I think that's unfortunate and, frankly, in some cases, malpractice. So let's get into it.
The first one that we want to talk about is APOB. Deep, talk to me like I'm 2 and I have no idea what this means. It's APOB, right?
It is actually short for apolipoprotein B. And most folks understand what a standard lipid panel is, or these very old antiquated terms like good cholesterol and bad cholesterol. And that doesn't make any sense at all. Cholesterol itself is one molecule. Cholesterol is actually very important in our body. It is the precursor to many of our hormones and our steroids, and it lines our neurons to ensure that we can transmit electrical signals throughout our body. And so we need cholesterol. And, there are even more antiquated physicians who will say, well, you need to stop eating so much dietary cholesterol. And that doesn't make any sense either, because about 80% of the circulating cholesterol in our bodies is actually produced de novo, meaning it's produced by our own cells because we need it as a core building block for many of the functions that we just mentioned.
Can we just stop right there for 1 second?
Sure.
So if you eat cholesterol, it doesn't raise your cholesterol.
If you eat an unbelievable amount of cholesterol, you may see a very slight increase in your cholesterol numbers. The 20% or so that's being absorbed through your intestines, even that, most of that is being produced by our livers and secreted into our gallbladder and down into our intestines. And that's what we're actually reabsorbing. But this all started in the 1980s with this whole thing around eggs and whether or not this was a good food or not. And I think medical education tends to rely on these euphemisms and these lines that are meant to just help you remember what to think about. And so some of these older docs would just remember those studies, and those have been proven over and over and over to be misleading. And even the American Heart Association has debunked that in many updated sort of analyses. And so dietary cholesterol is very unlikely to be the major driver and culprit of increased cholesterol levels in your bloodstream. Most of that is caused by our own body creating cholesterol.
Got it. So if I'm eating a bunch of eggs and I'm eating a bunch of dietary cholesterol, there's not a direct correlation with the cholesterol that's going to be in my bloodstream or in my veins or affecting my cardiovascular health.
Correct.
Where does that stuff come from, actually? The cholesterol that we're talking about, the ones that we don't want to build up of in our system. Where does it come from and how do we calculate it? And is like getting my cholesterol checked at the doctor really the best way to do it? Tell me.
So most of it's created by our liver and several other cells throughout our body that are creating cholesterol to be the building block of many of these hormones and molecules that we talked about. What we are actually measuring when we check a lipid panel and we tell you what your LDL cholesterol is, that is a calculated measure of the concentration of cholesterol that exists within those LDL particles, low density lipoproteins. Lipoproteins are merely the shuttle that carries around cholesterol from our peripheral tissues, our muscles and our fat cells to our liver and back and forth. And so there is some data that having high density lipoproteins in our system can be protective. But even that is being debunked a little bit now. And again, if you really hear what I'm saying, it's not the cholesterol itself. It is these shuttling molecules, the lipoproteins that we actually care about. Cholesterol doesn't just exist sort of floating around our bloodstream. So when we're checking a standard lipid panel, it's a calculation that's done on the concentration of cholesterol within things like low density lipoproteins. But we don't care about that. That doesn't actually matter. That doesn't track as well as some of the other things that we're about to talk about. The lipoproteins themselves, these are things that are atherogenic, meaning why do we care about any of this? Because downstream, elevated number of particles of lipoprotein can cause heart attacks and strokes. How that happens, we'll show that in a figure here, is the lipoproteins enter the lining of your blood vessels. They kick off an entire cascade where macrophages come in, immune cells come in, they start to form these things called foam cells. And that over time builds up all this cellular debris and calcium and foam cells. And it starts to decrease the diameter slowly over many years of that tube, of that pipe, of that blood vessel. Once that diameter gets so narrow that no blood is able to flow past that blockage, that's when we have a heart attack or a stroke. And it's a whole complex physiology there. But what people completely misunderstand is that it's not just naked cholesterol floating around in our bloodstream. That's a different kind of condition, a major problem in some ways, but that doesn't happen. It's the lipoproteins themselves. So when we're talking about lipoproteins, what we want to understand and what we're talking about with apolipoprotein B, ApoB. ApoB is a protein that wraps around these lipoproteins. ApoB includes, it's a category of molecules that includes your LDL, includes other things called your VLDL, your IDL, your chylomicrons, which shuttle triglycerides around in your system, and something we'll talk about next, which is your LPA. So ApoB, that broad category of lipoprotein proteins, they are the things that we actually care about, because a higher level of ApoB would suggest that you have more of these particles floating around your blood. And if they do get into your blood vessels, that's when it kicks off the cascade for a downstream heart attack or stroke.
I think I kind of understand it. I remember reading one time that when they initially understood that there was calcium buildup in the arteries, that they thought it was because people were getting too much calcium, right? Like they were like they were drinking too much milk or whatever it was. And so the science has continued to evolve from those very early days into trying to figure out from your standard lipid panel what's going on to now calculating the number of these carriers. Is that right? These
That's
ApoB
right.
carriers. And I guess that makes a little bit more sense to me intuitively if it's just the number of things bouncing around inside of your art. I mean, remember, I'm not the doctor here, guys. Bouncing around inside there, it should be that it's the number and the quantity of them, maybe as opposed to what's inside of there. So is there like an accurate test? This APOB, this is an accurate test that you can get? Is it something that's part of your standard lipid profile? Is it something your
It is
PCP is going
not
to do?
It is not part of your standard lipid profile. It is not part of what most primary care physicians, would order, would know to order. It is, however, part of most of the professional society guidelines from the cardiology, from our cardiology colleagues, whether it's American College of Cardiology, the European Atherosclerosis Society, and all across the board. They understand that apolipoprotein B, this protein that is wrapped around our carrier shuttles, that is the thing that is most predictive of the downstream myocardial infarctions or strokes that we care so much about.
What increases the number of APOB in your bloodstream? How does one decrease them? And what is a target number you want to see come back on your blood work?
Much of this is genetic. There's on the far end of the spectrum, we have people with things like familial hypercholesterolemia who just tend to produce more of these problematic lipoproteins, these ApoB particles. High triglyceride diet, high carbohydrate diet has also been shown to increase the level of ApoB in our blood. Typically, we are looking for a level of 90 or less. Even better is 70. If you follow the Dr. Atias of the world, they're putting themselves on medications in order to drive that number down to what we call infantile levels, down to about 40 or 50, where that's what we see in newborns when they're sort of first coming out. And the theory is, you don't see newborns having heart attacks and strokes. I think the data is still to be determined on whether going down that low actually provides any additional benefit. But theoretically, all the modeling we've done is get that as low as you possibly can. There's a whole other conversation about whether or not we should be using medications for that. There are a few proven ways to decrease ApoB in our blood without medications. Cardiovascular exercise, driving up your actual aerobic capacity, decreasing carbohydrate intake, decreasing triglyceride and saturated fat intake. When you don't have all of that kind of floating around in your body, you don't need as many of these shuttles to start moving them from different parts of our organ system. And so those are the primary ways that people are addressing ApoB. And that's a lot of the guidance that we give to our patients as well. On the
What's
pharmaceutical
the drug?
side,
Yeah.
on the pharmaceutical side, statins, whatever your belief on those are, there is overwhelming evidence that it will drive down ApoB and LDL, which is again what we said was a component of ApoB. But there are other medications, things like bempedoic acid, that have great data around decreasing ApoB. There are many new sort of therapies on the horizon that are coming out and are in phase 3 trials right now. Obicetrapib is one of them. It's a monoclonal antibody that targets some of these carrier molecules as well. And we'll see what happens sort of over time. But I do think our arsenal is growing slowly and slowly on how we can start to decrease and drive down ApoB.
All right. One more follow up on ApoB, and then let's move on. You say that you could be genetically predisposed to having high levels of ApoB. There are lifestyle changes that you can make to reduce the levels of ApoB, including increasing your cardiovascular exercise, decreasing the amount of saturated fat, and decreasing the amount of carbohydrate intake. But if you take this medication to drive down ApoB artificially, I guess, where does all the stuff that was inside the ApoB go if there's fewer of these, shuttles to move all the stuff around?
Well, there's a whole pharmacology lesson there, Jack. I think how statins work is by inhibiting an enzyme called HMG-CoA reductase. And that's one of the top level enzymatic processes that starts the entire cascade of how we create cholesterol in our body de novo, meaning our own cells are actually producing this. Again, it's not decreasing your dietary cholesterol in any way. There are what we call bile acid sequestrants as well, which will kind of go into your intestines and any dietary cholesterol or any of our cholesterol that we've secreted into our intestines, it'll bind that up and help you pass that in your feces. But for the most part, these medications are all working on the pathway that creates cholesterol to start with in our own bodies. So by blocking that, we can decrease the amount of carrier shuttles that are needed because we have a lower amount of cholesterol floating in our blood.
Terrific. I was just smiling to myself because here I have such a luxury to pick your brain and to dig in deep and like get this extra special time with a doctor. And I think that's one of the things that our clients at Rebel Health appreciate is you take time like this to explain all this stuff to them. Okay, let's move on to the next one of the 6 things that your doctor should be testing you for. And if he doesn't, it could be problematic. What's number 2?
Number 2, Jack, is related to ApoB. It's actually in the ApoB family. It's called lipoprotein A. And I know these are confusing. There's all the same terms with the lipoproteins and the A and the B and whatever. But lipoprotein A is another protein that wraps around some of these carrier molecules. Lipoprotein A is almost 100% genetically derived. That's why it's a little bit different and a different way that we sort of understand cholesterol and our risk versus ApoB. Lipoprotein A has been shown to be something like 5 to 10 times more atherogenic than all of the other ApoB particles. So we mentioned, we're showing in the figure here, apolipoprotein B. Again, I'm sorry for the confusion on these terms, but I didn't make them up. Includes LDL, VLDL, IDL, chylomicrons, as well as these other particles, lipoprotein A. It makes up a very small part of that overall ApoB picture. About 70 to 80% of ApoB is driven by LDL. The other 20% is made up by these other things. Lipoprotein A probably accounts for something like 2 to 5% of your ApoB. But it is important because it is such a high genetic marker of atherogenic particles in our bloodstream. One can have a normal ApoB, a normal LDL particle, a normal LDL cholesterol on their standard lipid panel, yet still have an elevated LP little a. That's how we sort of talk about it, LP little a. And they are at much higher risk for cardiovascular disease. My cousin, 45-year-old man, he had a massive heart attack about 4 months ago or so. His lipid panel was normal, quote unquote, and he didn't have diabetes, didn't have any other risk factors. And everyone chalked this up to some kind of crazy fluke. No one ever checked his lipoprotein A, LP little a, which was off the charts. There is some data to suggest South Asian cultures and others just have this genetic predisposition. And if you don't know this, you're not taking all the other steps. There's not much, frankly, we can do right now to drive down your lipoprotein A. it is, again, so genetically driven. There are some interesting new therapeutics on the horizon that are, again, in phase 3 trials right now that actually have been shown to decrease LP little a. There are some other conditions like being pregnant, for example, can drive up your lipoprotein A, and a few other things that are kind of rare. So some people say you should only check LP little a once, which I don't agree with. I think you probably need to check it twice, just to one, confirm that that first reading was accurate, and two, make sure that there was no other condition that may have inaccurately raised that level. But in the absence of any other sort of risk factor, we know that having a high LPA is something like 25 times more likely to cause a heart attack than even having a high LDL. It's just that your LDL particles far outnumber the number of LP little a floating around. So most people ignore this. In my opinion, and I think that data and science totally back this up, is if we're not checking this and we're not actually helping you manage and mitigate all of your other risk, we're doing you a great disservice by not understanding what's actually happening in our body. These aren't expensive tests either, Jack. Both of those tests, the ApoB and the LPA, are probably $10 or so, and they can give us such important information to actually help with behavior change downstream.
Okay, that's terrifying. There's a $10 test that you can take that will let you know if you have a 25% chance greater, 25 times more probability of having a heart attack, $10. And your typical primary care physician is either unaware or decides not to test for it. And you could just be walking around with this thing inside of you that is a ticking time bomb that could just be easily found out about and treated with a $10 test. This is like malpractice, negligence, criminal, tragic, disgusting, horrid when you think about it. Who's responsible for establishing the typical panels that if you just, okay, this guy got to check his cholesterol and we just like, put the order in, who like what professional body or whatever is coming up with the standards that doctors just pull off the shelf to use in situations like this?
There are a few, Jack. There's something called the U.S. Preventative Services Task Force, the USPSTF. They set the guidelines on what they believe the evidence strongly suggests makes sense to check. The problem with science, frankly, Jack, is we can have so many signals, so many great data points, so many randomized control trials. But before those actually filter into these kind of governing bodies and they do all the analyses, they have their scientific statements and their subcommittees on cholesterol sort of meet, and that happens every 5 or 10 years, and revise the schedules. It's only then that they get placed into clinical guidelines, which then even take a few more years to filter into real clinical practice. I can't remember this stat, but something like 50% of clinical guidelines, true clinical guidelines, have been agreed to by these big professional bodies, which is already a late stage sort of phenomenon, are not adhered to by most primary care docs because they don't have the time, they don't have the knowledge, they don't understand how to interpret them. They think, oh, this is something that cardiologists will order. My gut sense, honestly, is these people aren't bad people. They're not bad doctors on purpose. The system puts them in a position where you have 7 minutes to see a primary care patient in this country. And if you go back and look at some of our old videos on the state of sick America, you can learn a lot more about that and why that is. But when a typical physician has to check through 15 different boxes just to keep their job and keep the train moving, they don't have time to learn about these things, to interpret them, to incorporate them into day-to-day clinical practice. So unfortunately, most practices are at least a decade behind the current understanding of good science and good data. And we are just in that kind of time frame in our
You're
practices.
much kinder than I was going to be. I was going to pull that like that young girl, like the climate, lady. What's her name? Greta something or other. I
Greta
was about ready to
Thunberg. Yeah.
start screaming that you should be ashamed. You should be ashamed that there's a $10 test that you can give somebody that predicts 25 times more likely they're going to have a heart attack, and you don't have enough in your to order this or just put it in your standard panel or to watch one friggin' podcast or read an article or anything. Geez, $10. Anyway, I'm getting
Well,
heated.
the Health Gangsters as well is another video you all should go out and watch. I think a lot of this ultimately comes down to who's going to pay for that. And if insurance says, oh, that's not a test that we recognize and it's going to cost the patient $50 out of pocket, or we're just frankly going to deny that claim, then we've not collected important information that can truly change our plan and change someone's life because of profit and greed and the gangsters that run our lives.
Somebody should do something about all this.
I think I know who, Jack.
I think I know who too. And the more I learn, the more convinced I am that something drastic needs to be done. And I'm honored to be on this journey with you to right this wrong. All right. How are we on LPA, LP little a? Did we cover that? Do you feel good about it? Because
I think we've talked
talk
about
it
that
anymore,
one.
I'm going to lose my mind.
I think we've talked about that one clearly. We will next cover something that is semi-related, and all of the letters and nomenclature become very confusing. I'm very sorry about that. Again, not my call here, but let's talk about something called the ApoE gene. This is a gene, Jack, that codes for how we metabolize saturated fats and how we shuttle around saturated fats and cholesterols, particularly in our brain and our central nervous system. This is not a molecule per se. This is a gene. When we talk about genes, they're different alleles, meaning they're different types of these genes, variations of them. Some genes, like the genes that code for familial hypercholesterolemia, there's something like 1,600 different alleles. With ApoE, we have about 3 alleles that we think are important and that cover the majority of the population. There's a 2, a 3, and a 4. So let's talk about what that means. The vast majority of the population has ApoE3 status. That means that we have inherited one ApoE gene from our mothers, one ApoE from our fathers. And if both of those are 3, that's the most kind of predominant genotype that we have in our population. Why we care about this, Jack, is because ApoE is one of the strongest predictors of downstream development of Alzheimer's disease. This is something people are very afraid of, rightfully so. Many of us have had family members that have experienced this, and it's heartbreaking. I don't know, Jack, if you've had other family members or people you know that have had Alzheimer's. Have you?
Yeah, I absolutely have. It's my grandmother.
You probably saw what that looked like. And I've worked in memory care units where people are literally locked in because they cannot function in society and they'll just wander off. And you see the movies around what this sort of looks like, or many of us have lived experience where you don't even remember your own child. You don't even remember what happened 5 minutes ago. You ask the same sort of questions, and that's extremely scary for many of us. I think when we talk about longevity and health span and living our best lives, none of us want to be 90 and living like that, right? We want to be 80 even and hiking the Rockies or traveling with our loved one, doing whatever we want to do, certainly not locked in a memory care unit, left to sort of our own devices and to understand, and have no sort of perspective on life from there. We can test, though, and understand what our actual risk is. There's a different allele. We talked about the ApoE3. If you get 2 3s from both of your parents, you're about the standard risk. Having an ApoE4. Having one of those at least doubles your risk versus baseline for the downstream development of Alzheimer's. Having both ApoE4, one from your mother and one from your father, so your own status is ApoE44, that puts you at something like 10 to 12 times the risk of developing Alzheimer's downstream in your life. If you have, on the other side, if you have a 2, you're protected in some ways. And so having an ApoE2 or 2-3, you will have a lower risk than the general population for developing Alzheimer's. So why does that matter? Well, frankly, at this time, there's not much we have as far as therapeutics and pharmacologics to prevent the development of Alzheimer's. The best we have are a couple of drugs that might slow down progression once it's already set in. But that's already kind of a late stage finding. Once you're forgetting where you are, what you did this morning, you're pretty far down that spectrum already. Slowing that down, sure, is good, but it doesn't prevent that. So the only 2 real treatments we have right now for Alzheimer's prevention are great cardiovascular fitness and great sleep. We talk about this with our patients all the time. I think sleep is the one people don't really understand enough and don't really tie together, but having adequate sleep has been shown over and over to prevent Alzheimer's, even if you may have one of these genes that puts you at higher risk. Cardiovascular exercise is certainly one that we've known of for quite some time that can stave off the development of Alzheimer's. The other one I will mention that I think does have good data around is social relationships. Being a social being, actually connecting and having folks in your lives and being in interesting sort of situations. There's some stuff I've seen on Sudoku puzzles and taking a different route to work and brushing your teeth with your left hand, trying to train your brain to think about different kind of patterns tends to formulate some sort of protection from that. But really, the biggest things we have are around sleep, exercise, and good social relationships. So let me pause there.
Yeah, I'm so glad that you laid out some things that we can do as individuals to put us at a lower risk of developing Alzheimer's. I don't want people to think that if you've got APO34 or 44, you're just doomed. Because if you were, you wouldn't really want to get the test, right? Like, you get the test, know your status, and at any rate, increase your cardiovascular health as best as you possibly can and sleep as best as you possibly can and get yourself connected and stay connected to community and have and find and build and maintain purpose. There's a little part of me deep that gets like laughs at us when we talk about community actually affecting health outcomes. It sounds so woo, sounds very hippy dippy, but it's actually legitimate. The science is pretty clear on it. There's a number of studies, and you can just experience it in your own life, the positive energy and feeling that you have by participating in community with people who share common values, interests, goals, etc. It's going to be medicine for you to be in a community. Cardiovascular exercise is medicine for you. Sleep is medicine for you. That is why those are 3 of our 7 pillars of longevity. And it's just something that's so simple, but so many people fall down on. They get isolated. They don't exercise, like they don't even walk. And then they're going to have a degradation just because they're not doing the things that are shown over time to prevent the onset or at least delay it or mitigate it of Alzheimer's and dementia. Personally, I'm lucky. I think I'm a 2-3. I know it's in my family. It doesn't matter to me. I am still going to max out my VO2 max because the effects of cardiovascular health on your general health and outcomes is so profound that literally everybody should be prescribed it and doing it upwards of 150 minutes a week minimum. And
Minimum.
yeah,
I mean, I think there's great data that says 300 minutes a week is really what you're probably shooting for. And
yeah,
Jack, you made a good point earlier about why do you want to know this information? I think a lot of primary care docs, a lot of physicians in general will often throw that line out. Well, what's going to change? And there may be some truth to that, right? No matter what your ApoE status is, no matter what your ApoB or LPA status is, we have a prescription for you, and that is maxing out your VO2 max. That is getting great sleep and all the pillars you just laid out. But there's a very powerful motivator that people forget about, that seeing this risk. And we've actually had patients that have told us, I don't want to know what the result of that test is. So if I have a higher risk of Alzheimer's, don't tell me. And they're right. And I totally understand that and appreciate that. But there is a driver there that really kicks you into another gear that says, I'm not going to end up like that. If I have even a little bit more risk, I got to do everything I can on the mitigation side to prevent myself from ever getting there. And it's much more powerful than I think we give it true credit for.
absolutely. When you have data in front of you, when you have your Whoop telling you that your HRV is in the toilet and your resting heart rate is through the roof because you had too much or even anything to drink the night before and your sleep was total crap, you're much more likely to cut the alcohol out, even subconsciously, if you're worried about your sleep. If you know what your APOE status is, it's just one more piece of motivation to stay in the game and to crank out that cardiovascular work. I promise you guys, if you haven't gotten started, I know it seems daunting and I know the beginning part is kind of hard, but once you get going, it actually feels good. The return is immediate. Your mood is elevated. You are more relaxed. You can easily handle stressful situations. Everything is better when you're working your cardiovascular system immediately, short term, medium term, and long term. I had no idea I was going to become such a cardio, acolyte, running around the country talking about VO2 maxing. But that's what this is, the year of VO2 maxing. Personally, I was at a 43 at age 47. I want to be at 50 before age 50. I'm trying to get 50 this year. That'll put me in elite status for my age. I don't care about being elite. I just care about being healthy and feeling good. And I promise you, if it sucks at the beginning, it gets better pretty fast. It gets better pretty fast, and it's an instant reward on your effort. Also with long term. All right, APOB, LP little a, APOE. We are now on to number 4 thing that your normal doctor is probably not testing. And by not doing that, he's leaving you at tremendous risk. Number 4 is LPIR. Dr. Deep, what is LPIR?
Jack, LPIR is your lipoprotein insulin resistance score. Again, I'm sorry for the terms. They all kind of overlap and it's hard to keep them in track. But the more you sort of wrestle with these terminology, you'll start to understand it a bit. There's a complex interplay between lipoproteins and cholesterol and our insulin resistance in our body. A great sort of father of lipidology, Dr. Bill Cromwell. I had the great honor of chatting with him a few months ago. He's now the chief medical officer of something called Precision Health Reports. It does a great job of bringing together all of your risk factors and showing that to you. But he was one that really invented and started to proselytize around LPIR. The reason we care about your insulin resistance score is what most doctors check on you is what's called your hemoglobin A1C. When you have so much glucose and sugar floating around your bloodstream, a process happens called glycosylation. That means there are sugar molecules that are attaching on to your red blood cells. When we look at a hemoglobin A1C, that's a general marker of how high have your average daily blood sugars been over the past 3 months or so. The problem with that is the hemoglobin A1C is, again, a late stage finding. By the time we've found that you have a hemoglobin A1C of 7%, you're diabetic. You have diabetes. From 5.7 to 6.4, you're in that pre-diabetic phase. We talk a lot about how many Americans are pre-diabetic and on their way to diabetes. I believe much of that is because people don't understand what their true risk is early enough to start making change. There are great studies from the American Endocrine Society that show having a higher level of insulin resistance, having a higher level of insulin, meaning hyperinsulinemia, which leads to insulin resistance, are precursors to the development of those glycosylated byproducts, that hemoglobin A1C. There's other tests that we look at, like a fasting glucose can give you a spot check. Something called your fructosamine is another glycosylated byproduct that shows you about the last 6 weeks. But we'll show on this figure here where lipoprotein insulin resistance score really comes in is several years before the development of even pre-diabetes, meaning you may be showing signs of insulin resistance 5 and 10 years before that hemoglobin A1C catches up. The entire time, you're doing damage to your body in what we call microvascular damage. These glycosylated byproducts start lodging in and causing very micro, small changes in our vasculature, in our organs, in our kidneys, in our brains, and causes all the downstream effects of diabetes. But often we don't even know that until it's much too late. So the LPIR score, out of any test we have for diabetes, including a hemoglobin A1C, the LPIR score is the most predictive score of downstream development of diabetes in one's life. Yet, until we started Rebel Health, I had never ordered this for most of my patients because most insurance companies don't pay for it. Most hospital systems don't even have it in their order set. And most people don't know how to interpret it or what to do with that information. So the LPIR score is one of the strongest predictors of downstream development of diabetes. And again, it's one of those eye-opening moments for patients when we're chatting about this and we're talking about their LPIR score is actually quite elevated, but their hemoglobin A1C is normal. They will say, oh, my doctor told me I didn't have diabetes and that everything was fine. Well, that's not the full story. You're actually doing damage and you're very much leading on the way to diabetes unless we can pull you back from everything that's going on in your current day-to-day life.
The numbers around prediabetes are astonishing, bewildering. Perhaps upwards of 100 million people are pre-diabetic on their way to developing full-blown type 2 diabetes, requiring insulin treatment, putting them later at risk of having to get their foot chopped off and all kinds of terrible, horrible things. That there is a blood marker that we can use to test to see well in advance the path that people are on, where we could divert them through lifestyle and nutrition into a path that's going to avoid diabetes and all the terrible, horrible things that go along with it, and we're not utilizing it, is again one of those you should be ashamed moments. Does this test cost like $50,000?
No, it's not $1,000 test. It's something on the order of $20 to $50. It's often incorporated into something we call your NMR profile, which looks at all of your various lipoproteins and your insulin resistance and gives you a great sense of overall how you're doing. That entire test is probably $50.
So for the price of like taking your family to Starbucks, you could get a test to let you know years in advance of all the other markers if you are on your way to being pre-diabetic and eventually diabetic, and then have the data in front of you to foster compliance and accountability to make the changes that will prevent you from having to get your foot cut off. I know it's a reach there, but really that's the eventuality of untreated type 2 diabetes. I think that there's a national shame happening right now I think that there is a national shame that's preventing both practitioners and patients from opening their eyes to the crisis, because everybody is a culprit. The individual people have guilt, the practitioners have guilt, the people that contaminate our environment with who knows, maybe airborne particles or in the water or in the food. We don't know for sure, but there are probably exogenous particles in our environment that are disrupting our systems and leading towards obesity and metabolic disorder. A collective national shame, because we're basically suiciding ourselves day by day. And it's astonishing to me. And you will have an opportunity to avoid such a fate and to congregate with others who have elected to avoid such a fate by seeking out and finding practices like ours. Doesn't have to be ours. Please just find somebody else. Find somebody who's going to give you these tests and offer to you the lifestyle interventions or guide you there, or at least dangle the things in front of your face and give you a good sense of urgency of what you need to do in order to avoid this terrible, horrible fate. Again, shame, guilt, national guilt around all of this, and be ashamed. I am proud to say that we are testing for all of these markers and that our people are avoiding these fates and doing the actions that they need in order to live happier, healthier lifestyle. So LPIR, lipid particle insulin resistance. Most people never even heard of it in their life. Could save your life. Well in advance. Next up, number 5, testing for visceral fat. What is visceral fat, Dr. Deep? Is that just the fat on my love handles? Is it the fat in my chubby cheeks? What is it?
So, Jack, most folks don't realize that there's several different types of fat in our bodies. The fat that you just mentioned, the kind of belly fat that we see, the double chin that we have, that's called subcutaneous fat. And while that's bad for all sorts of reasons, there's actually a much more sinister type of fat called visceral fat. Visceral fat is the type of fat that wraps around our organs, typically our intra-abdominal organs, starts to infiltrate things like our liver and our kidneys, wraps around our intestines, and it's what we call a metabolically active type of fat. Subcutaneous fat is really more of a storage depot, meaning we can put excess calories for a rainy day when we are about to go through famine. That sits in our subcutaneous fat. And when we need to call it back up in order to use that for energy to stay alive, it's our depot there. In a world where we have excess calories all over the place, obviously too many of us store too much of that without ever having to tap into those stores. So that's hence why 60% of Americans are obese or overweight. But visceral fat is actually much more deadly. Visceral fat kicks off an entire cascade of inflammation in our body. When I said it's metabolically active, it releases hormones, it releases what we call cytokines, which are these inflammatory markers, things like interleukin 6 and TNF alpha, that all cause downstream impact across every major organ system that we know. Even when we talked about lipoproteins and ApoB earlier on, we showed the figure around the particles entering into the lining of the blood vessel. They need to enter that lining through some sort of mechanism. There's one physiologic mechanism called transcytosis, but most of it happens through damage of the lining of the blood vessel. That can happen from high blood pressure, can happen from smoking, can happen from diabetes, can also happen from a general underlying inflammatory condition. Having visceral fat increases your chance and increases your risk of being in a general inflammatory state, which then allows all of these other downstream pathologies to start to occur. The problem is most people don't know that and they don't test for it in any kind of way. So we can talk about how to test for that next.
The visceral fat that you've got wrapped around your heart and your liver and in your guts that makes your little, belly stick out there is a petri dish for disease. It's like an invading alien. It brings its armies in order to take over your whole body and make you sick. At one point in my life, I felt like I was pretty healthy. You know, I could deadlift like 500 pounds and squat 400 pounds, and I could row a good 2K, but I was feeling like crap and I had a generalized like environment of inflammation. I went and got a DEXA scan, which, as far as I know, is the only way. Maybe there's other ways, or the best way. A DEXA scan where it measures your muscle mass, your fat, the types of fat, the visceral fat, the subcutaneous fat, as well as your bone density. And it showed me that I had something like 4.5 pounds of visceral fat wrapped around my heart and stuff, where there's really not supposed to be any, right? And when I saw that, again, this comes back to the value of the diagnostics. The value of the diagnostic is that it helps you be accountable. It gives you a reason to do stuff. If your doctor looks at you, thinks you're a little bit out of shape, and says, hey, you should probably eat better and exercise more, but he doesn't have concrete data with predictability of mortality and all the horrible things that could happen to you, you'd be like, okay, doc, I guess I feel fine, but whatever, it'll be fine. No, when you see that you have 5 pounds of visceral fat wrapped around your heart and you know that it is, when you say it's metabolically active, that scares me that this fat like has life basically. And it's gonna, it's not just sitting on your hips waiting to, fuel up the long cold winter. It's actually doing stuff inside of you. When you see that you have that and it comes back and it shows you're like, 90th percentile of bad, you make changes. And how many of you, raise your hand, how many of you out there have had your primary care doctor order you a DEXA scan? That's right. Absolutely zero of you. None. Not a single one. They don't have them in the offices. They're not in the general, MRI imaging centers and whatnot. You have to seek them out and you have to go to find them at where I have had good luck and where most of our members have had luck is at university sports science departments. They generally have this plus all of the other fancy machines that you want to get tests for. The O2 Max. I learned this one, the indirect calorimeter. That's a tough one to say if you're not a doctor. And you can go down to the sports science department. You can get all this stuff tested. And I think I'm leading us into one of our next topics. We'll get there in a second, but I don't think we dug as far into this brown fat and visceral fat discussion that you want to have, because I don't think even most people understand that there's different colors of fat. There's fat that does things. It has, metabolic activity. I mean, that it's crazy.
It is crazy. Brown fat is what we consider kind of good fat. That's what babies have. And that is burning calories as it sort of exists. Every compartment in our body is living in different kinds of ways. The white fat is what we mostly think about in when we think about subcutaneous fat, that adipose that kind of sits there for the long cold winter. But visceral fat is highly correlated with the development of type 2 diabetes, of cardiovascular events, of mortality, of these general inflammatory states that we mentioned. There are actually a few other ways to test for it. An MRI is probably actually the gold standard and can give you a little bit more information on the exact composition of that visceral fat. But what we care about is what you mentioned, is how many pounds of visceral fat do you have in your body? Having less than about a pound or so, depending on your body size, is our goal. For you to say you had 4 pounds of visceral fat, and now what, Jack? I think I remember you saying less than a pound, right?
Less than one, yeah.
That's amazing. You've literally added years to your life because of the metabolic reset that sort of happens there, of the kind of mechanisms in the background that are stopped in their tracks by losing visceral fat. The problem is most folks, even at normal weight, whatever you want to call it, skinny fat or normal weight obesity is how we sort of say it in the medical community. When we see someone who has a normal quote unquote BMI and then has a huge heart attack, there's only a few things that will be causing that. And we talked about one of them, something like a latent LP little a that no one ever checked. The other one is having a high degree of visceral fat that no one ever really understood. And you may look and appear normal weight and your clothes and everything fit, but you're a harbinger for these conditions downstream that if you don't know that information, you may not kick yourself into high gear to actually help address that. The good thing is visceral fat, when you start to lose fat overall, when you put yourself into a caloric deficit, it tends to be the first kind of fat that you lose. And people often get frustrated in that I'm doing everything I'm supposed to be doing, but I can't get rid of the belly fat. It's still sitting there. My butt's still kind of bigger than I want, and my pants still aren't fitting. What they don't realize often is, well, if we took a look inside you, and that's why it's so important to get these things tested, like DEXA scans, which we MRIs maybe will sort of see the cost of those decrease over time, but MRI or DEXA scans are pretty close to just as accurate there. And so having that as a $100 or $200 test gives us this information to actually push us to action. Things like intermittent fasting, high intensity interval training is probably the best data that I've seen. General aerobic fitness and starting to shed excess adipose from a subcutaneous standpoint as well, all has benefits in decreasing your visceral fat. So again, we want to be somewhere south of a pound, and we need to be testing that and taking a look at that probably once a year to understand what your risk is. And if you're changing your body composition and going through a program of any type, it's often helpful to kind of see that multiple data points throughout a year.
I'm laughing over here because I'm thinking this is going to date me. I'm not a boomer, but quite. Jane Fonda, she had it figured out, man. Jane Fonda, back in the 80s or whatever, she put out this whole line of aerobics videotapes. And man, aerobic health is going to help you in so many ways. But again, on this one, you could just get a $150 test. Your doctor could just have a relationship with the facility that has the DEXA scan. And for your annual physical, you could just go down there and get a scan. It takes like 15, 18 minutes or something like that. And it's non-invasive. You don't have to do anything. You don't have to put anything over your genitals. You're not getting nuked by x-rays. You just lay there on the bed and the thing just passes over your body like Star Trek style. What's hilariously sad and disgusting is that there are people that operate these DEXA machines that still don't even realize it can be used to analyze your visceral fat. They think it's just for bone density and osteoporosis and whatever else. It's just mind-boggling. I guess
Jack, I've argued with the radiologist that we sent a patient to for a DEXA scan. We were very clear about what we were looking for: body composition, subcutaneous fat, visceral fat, as well as bone density. This is not something we're taught in medical school or in residency or in training unless you've sought this information out yourself. This radiologist literally told me, well, that's not possible for a DEXA scan to measure your visceral fat. And I had to send him de-identified reports of at least a dozen other patients who literally got this test and had this thing reported. And of course, he never answered that because he probably felt stupid. But this is a radiologist, right? These are the people that we're counting on to do these diagnostics and to give us this information so that then we can go act on them. It just shows you how antiquated and broken the health system is when physician to physician, I can't even have a collegial discussion about something that's very well known to many of us. It's still, unfortunately, not known to most of us.
Dr. Deep, somebody needs to start a real new medical school that actually teaches people all this useful stuff that we're just like sussing out and throwing out onto YouTube. That's not just like esoteric, weirdo, woo-woo, wave a wand at your water, Gary Brecka style. This is like real science that's just astonishing that people don't know. I've gotten the test. It rolls over your body. You can see. It just measures, I believe, density, right? Like you can just tell what the different tissues are based on their densities. Anyway, I'm getting heated because the whole thing is such a disaster and it's so preventable and avoidable. You just need to know who to talk to and where to go. The next one, we've talked about the final one. We've talked about 5 tests that your that's 10. We're talking about 5 tests that your doctor so far should be giving you they are not. And they could be leading you down a dark path and off the cliff of chronic disease and misery For $50, for $100, they could be testing you and giving you the information that you need. The sixth and final one is the VO2 max test. I know what it is. I had one this year. It's crazy. It's fun. It's wild. You're like Bane for a minute. But tell me, Dr. Deep, why doesn't the doctor, instead of just Jack, explain what the VO2 max test is and why it's important?
Sure. So the VO2 max is the number of milliliters of oxygen per kilogram per minute that our body is actually using in our mitochondria, which are the powerhouses of our cells, to create ATP, which is the currency of energy in our bodies. So, said another way, VO2 max is a composite score of how well a whole series of organ systems are working in our body in order to extract oxygen and use it in a productive way. The reason I love this test, Jack, is, well, two reasons. One is it tests so many different things just with one measurement or output, meaning it tests your lung capacity, the capacity of oxygen to diffuse between your lungs and your alveoli into your blood, the ability of your heart to pump that blood effectively to your peripheral tissues, the ability of your peripheral tissues to extract that oxygen from your blood into skeletal muscle, the ability of that skeletal muscle then to use that oxygen as a substrate in your mitochondria and to produce ATP. So that's reason one. Reason two is, out of every measure I've seen in all of medicine and all of healthcare, if there were one test I was going to get and I was going to recommend, it is the VO2 max. For the reasons I just mentioned, but also for this reason. It is one of the most predictive measures of downstream morbidity and mortality that we have in all of healthcare. Let me tell you a crazy stat, Jack. If you are a lifelong smoker, you have what's called a hazards ratio of about 40% higher chance of death over the next decade than someone who's not a smoker. That's pretty bad, right? None of us want to put ourselves at a 40% chance, higher chance of death over the next decade. If you have a low VO2 max versus an elite status VO2 max that you mentioned earlier, you have a 400% higher likelihood of death and disability over the next decade of your life versus someone that is in the high category. Let me say that again. If you are in the low category of VO2 max for your age, you have a 400% higher chance of death over the next decade than someone who is in the elite category. It's astonishing. I don't know of any other measure that is that dramatic. Again, when we talk about something like smoking, we think, man, that's really got to be putting you at high risk. And it certainly is a 40% chance higher risk, but 10 times, an order of magnitude higher of having a low cardiorespiratory fitness marker versus that in the high and elite sort of categories. It's not that sort of fatalistic, meaning even if you move just from the low category to the moderate category, you cut your risk of death in half over the next decade. So we're not saying you need to go out and be an elite athlete, an elite performer. I think many people can get there with the right kind of work, with the right kind of dedication. But even moving up one category, one notch, the studies are really well done and are very compelling that you're literally adding years to your life by improving your VO2 max. I don't know any practice that does this at scale, as a regular measure and test for most of their patients. It's almost seen as, like a thing athletes do. And we can talk about what the actual test actually, how it's performed next. But most doctors never have heard of this and certainly don't order this for their patients on a regular basis.
Well, I can tell you what the test was like. I got one last fall. They basically put this the cardio metabolic cart. They wheel it in. It's like a medical thing. There's like four dudes in white lab coats, and everybody. They got a medical student in there. They got an intern. They got they got the exercise science guy, and they put this mask on you, and there's a tight seal, and it you breathe in and out of this mask as they slowly crank up the speed of your cardiovascular activity. Lots of people run on the treadmill, some people bike. I did a row in this particular instance. And over the course of 18 minutes, the wattage just keeps getting cranked up. At first, it's like 3 minutes and then 3 minutes, but then it's like every minute and then every 30 seconds. And you go until you literally cannot go anymore. And side note, I was very proud of my VO2 max performance, not because of the number, which I want to get up, but because I mentally was able to push myself past the point of diminishing returns on the VO2 max. So the whatever the blood oxygen per kilo, whatever per minute or whatever peaked and then started to decline. And I pushed past that. And I thought I was suffocating to death. Like I tried to rip the mask off. I don't want to scare anybody. Please go get it done. I ripped the mask off and man, I was gasping for air, but I pushed past my body's ability to process oxygen, basically. And I didn't quit before my body quit. So I felt very proud about that. But again, a simple test that one can do that will tell you where you are and can predict how likely you are for to get all kinds of disease and death and mortality and whatever. I'm not the doctor or the scientist, remember. And you can improve it. Now, this is the part that I want people to take away is there's like two components to improving your VO2 max. One, you have to build the base of the pyramid, and that's done through easy zone 2, low rate aerobic exercise, which for most people who are out of shape just means walking. It just means walking. Maybe walk in a place that's got some light hills, but do it for an hour and build up to it, but just walking. If you're an athlete and you already have a pretty decent VO2 max or good cardio, it's a light jog and a lot of it. If you want to take it to the next level, then you can do high intensity interval training as well, where you maybe go all out, 1 minute on, 1 minute off for 4 rounds. And then you grow that to 2 minutes on, 1 minute off, or 2 minutes on, 2 minutes off, 3 minutes, 3 minutes, 4 minutes on, 4 minutes off, 4 rounds. That's one of the best protocols out there to increase your VO2 max. So if you're just fresh off the couch, just start walking. You can walk to save your life. Just walk. It's
I agree, Jack. And it doesn't need to be more complicated than that. And when we talk about things like mortality and morbidity, that can kind of be scary. But I think putting in terms of functional independence is also important. If you have a VO2 max of 40, you're probably able to jog 6 miles an hour, so a 10-minute mile or so on flat ground. If your VO2 max is 20 or below, you have a hard time going up a slight incline or going up a flight of stairs. So when we think about where we want to be in 30 and 40 years from now, each of us, even if we're staying well trained, even if we're getting after it with our training program, we can expect to lose somewhere about 10% of our VO2 max per decade. So if you're 40 and your VO2 max is 40, by the time you're 80 or 70, your VO2 max is under 30. You're definitely at that 25 kind of range where you're going to be huffing and puffing and perhaps not even able to go up a flight of stairs. That's not longevity. That is not health span. That is merely being alive and barely making it. That's not what any of us want. So the importance of this is you need to train yourself up to as high a VO2 max as possible right now, so that even as we see that slow, steady, ever-present pull of gravity on our VO2, we will still maintain great functional ability. These 70 and 80-year-olds you're sort of seeing that are doing marathons and, their VO2 max is still probably 40 or so, but they started at like a 70 or an 80. An elite runner athlete, I think the highest ever recorded VO2 max is like just over 100, but a lot of like super athletic folks are in the 70s and 80s. And that's like, we're talking about the top 0.001% of the population, but even the top 2% of the population, top 5% of the population, if you're 50, Jack, and you have a VO2 max of 50, that is a great benchmark to be at. You know that by the time you're 80, you're still going to be able to hike around with Rosie and go travel around and do the things that you want to do. That's what actually matters. I think the last comment I'll make here is just to double down on sort of what you said on how to actually train VO2 max. It is your zone 2, meaning about 60 to 70% of your max heart rate. You need to be getting to at least 30 to 60 minutes a day. And I know this is hard sometimes to sort of filter into our lives, but you got to find the time, because what is the point of living if you're just going to be huffing and puffing every time you're trying to get from the car to the house? And once a week, what I like to talk to patients about is there's high intensity interval training, which can very much help with your VO2 max, but it's actually this 4x4x4 split that tends to have the best data that I've seen. 4 minutes at 90% effort, meaning you're not sprinting. You know, the high intensity intervals, you're going all out for gassing yourself, which does have some benefit again, but really that 90% or so max heart rate. So if your max heart rate is 180, you're looking for 160, 165 for your heart rate for 4 minutes. Take 4 minutes off and just walk. Do that 4 times. 32 minutes of your life once a week, and you will be adding years to your life. All of us can find that somehow, somewhere. So I encourage you again, VO2 max is probably the most highly predictive measure that we have in our arsenal. Very few people actually test it. It's an easy to find test. It's not that it's difficult to find. Doing it is slightly uncomfortable, having the mask on, but the data that we get from that is so important. And it gives you the motivation you need to really engage in the right kind of training program to add years and add functional years to your life, most importantly.
Amen to all of that. 2024 is the year of VO2 maxing, and there's good reason for it. With my social media following, I'm trying my best to be a leader in this and bring people along on the ride. I have decided this year to become a runner. I've never been much of a runner. I'm a big guy. I'm 6'4", 250, look more like a football player that can't run. I'm great on the rower. I've got good cardio, but I've never been able to run. And so I'm really dedicated myself to it. And I've gotten over the hump. My legs don't hurt anymore when I run. I can actually put in good mileage. I can actually do my sprints and my intervals, and it feels good. I know it sucked at the beginning. And guys, I know the long comeback road from cardio, sort of being out of shape from cardio sucks. There's no question about it. But you got to do it. And it gets better pretty quick if your body's adaptive, which we all are. And pretty soon you'll get positive feedback immediately, elevated mood, lower stress, better sleep, and you're putting money in the bank for when you're older and your grandkids want to go on vacation and your kids are, the parents are like, well, we can't go do anything fun because grandpa can't walk around anymore. No, that's not going to be you. You're going to be the one whose whole family goes off trekking and wherever, or goes to the beach and goes surfing at 80 years old because you heard this podcast and changed everything about your life and got your doctor to give you all these tests that you should be getting so you can focus yourself, get up off the couch and start moving around. And please just emphasize so much. Just start walking. It's the easiest thing and it's going to have direct benefits. So just get off the couch and get going. Dr. Deep, I want to thank you so much for being with me today. I think this has been a exceptionally informational podcast. These 6 factors, these 6 tests, these 6 diagnostics are things that your doctor, you out there, they should be testing you so that you can see your condition and make your moves now to head off chronic disease and to have a happy, healthy lifestyle. Dr. Deep, thank you so much. Guys, please watch our video here on precision science and precision health and precision testing. Learn about the future of healthcare and how we're rolling it out at Rebel Health. Hit subscribe, share, and thank you so much.